Andre, can you confirm that they can hear us? I think there were comments that they couldn't hear earlier. Good. Thank you so much, Kevin, for the stretches. I think those are exercises that you can do in the comfort of your office or health facility or wherever you are. And it's recommended that you do that every 2 hours. So take a standing break and stretch break every 2 hours. NCDs are on the rise and currently are the leading cause of mortality in Rwanda. So prevention is much better than cure. Again, welcome to this month's Health, Science and Innovation platform. My name is Dr. Brenda Katera. I'm the country director for CHAI in Rwanda, Clinton Health Access Initiative. And I'll have the pleasure to be your moderator for today. Today's session is going to focus on maternal and child health. And we have made tremendous progress as a country in achieving and remarkably lowering our maternal and child health indicators over the last 2 decades. We've seen maternal mortality rates drop from over 1,000 per 100,000 to now just slightly over 200 per 100,000. And likewise for infant and under 5 mortality, that has reduced from over 192 per 1,000 live births to 29 per 1,000 live births as per the last DHS. However, we've seen a lot of progress, but there's a lot of stagnating over the last few years. So what can we do to further drive down those indicators and really achieve good health outcomes for our mothers and children? Stunting is a big priority in this issue. Almost 1 in 3 children is stunted, which is a serious thing. We've seen some declines, but they need to go much further. And we know that stunting is not just a health condition, but it has cognitive impacts that lead to economic productivity later on. So it's a serious issue that we need to address. Immunization rates are really high in terms of childhood immunization, with coverages over 95%. But where are those children, the zero-dose children? Where are they? Where are we missing them? And how can we achieve the last mile in the immunization targets? So today's session is really going to focus on maternal child health and what can we do as a community to further address the remaining gaps and drive down the indicators that we're seeing. So we are looking for innovative approaches, most importantly, leveraging the data that we have and using evidence to come up with evidence-informed solutions. So we have an exciting discussion ahead of us. We have 4 great speakers that will talk about some of the innovations and data perspectives that they are seeing using our current context. We'll have Prof. Janine Chondo talking about Mom Connect initiative. Keep your ears tuned for that. We'll also have Dr. Aline Umbiei, the current division manager for the MCCH division within RBC, talking about malaria and nutrition in MCCH. We'll also have Piero Irachiza talking about evaluation of the immunization program and what are the insights that we are getting from the data that we are seeing. Lastly, we'll also have an AI expert, Mukundo Prince, talking about application of AI. How can we leverage big data analytics, AI, in maternal and health-related research? So keep your ears tuned. We hope to make it very interactive. Please ask questions during the discussion points. And at the end of the day, we'll hope that we will have achieved a better understanding of what research is available to us, what data do we have available, and how can we incorporate that in crafting innovative solutions to address a critical issue in Rwanda. So join me to welcome our speakers for this platform. And thank you so much to the RBC team and partners that have organized the session. So first and foremost, we'll welcome Prof. Janine Chondo, who will lead us through the first session. And for the speakers, we have 15 minutes so that we can reserve some time for discussion at the end. Over to you, Prof. Yeah.
Thank you so much, Dr. Brenda. And all of you to thank. Can you hear me, those who are online? No? They can't hear me? They're here? Okay. All right, can you hear me now? Yeah. Can you hear me now? Okay, I don't know. So, oh, cool. Fantastic. I'll try also to speak a bit loud. So today, we are going to present one of the studies that we did that came out discussions with the head of division, at that time was Dr. Felix, who was looking at why are we having almost 98% of our women delivering at the health facility, and yet few of them are going for ANC, right? So there's a discrepancy there. So the study of today work at seeking, it's not teaching. Today I was talking to people here, they say, how do you pronounce your organization? I said, no, it's just simple, Seeking. So Seeking is an organization, is a private NGO that works here in Rwanda, but also standing also in other places. And we do perform services related to incubation. We receive students, we receive interns. We also do evaluations a lot. We also write grants, we also teach. So we are in between the researchers, the academia, but also we are here as well to support the policymakers. So next slide. Can you see the next slide? All right. Coming up. Just to say that recently we applied to be the CPD provider, so we can also continue supporting professional councils like Council for Doctors and Dentists, as well as nurses. So we've been approved. We also been approved also to receive Fulbrights as well, to receive them so that anyone who wants to use our data, they are free to use them. And recently also we were certified as a data controller and data protector. It's very important for research institutions here to go by the laws. Next slide, please. Thank you. On our next slide, we'll talk about the project backgrounds. As I said, we started by discussing with the Minister of Health, RBC, understanding what is that can be done. So as a background, as Dr. Brenda said, a lot has been done in terms of maternal and child health, but few need to be done. And probably those are the hardest parts to move forward, because we've done the majority, then we need those small numbers to pick up what we're supposed to do. So those are the outline of the result that we have, but we'll come back to it. Next slide. On our next slide, we talk about the objectives was actually to assess the quality of antenatal care. So one of the hypotheses was, why don't you go to antenatal care? Is it because you don't trust it? Is it you don't believe it? Or it's far? Why is that? So we wanted to assess how the providers, but also the beneficiaries, perceive antenatal care, using their knowledge. And also we wanted to explore factors influencing the satisfaction rate at both sides, demand and supply side, as well as utilization of, I don't know if you know the PHQ-9 tool. You use it a lot here at RBC. It's a patient health questionnaire 9 tool for assessing the mental health, depression especially. So we used exactly the one that you used a couple years ago, 2019. And also, we also recognize the effort of community focus and community factors as a potential mediator. We're going to talk about that. So we wanted exactly to identify the challenges so that we can bring solutions based on the challenge. Next slide, please. So in terms of method, the volume. All right. Can you hear me? Maybe I'll be talking like this. So we did both quantitative and qualitative methods. So on qualitative, we did a lot of focus group discussions. You can tell there are 49 women who missed antenatal care. So we went to those who didn't come for antenatal care and asked them, why you didn't come? What are the causes? What are the issues that you get there? And then also we asked their husband about the perception about antenatal care. But also we also had community health workers focus group discussion. Also we use stakeholders, people here, but also internationally to understand what are they doing in terms of antenatal care, but also postnatal care. In terms of quantitative data, we collected around 1,000 women attending PNC, postnatal care, but around 1,000, almost 200 women attending ANC. We also asked questions around 64 health providers working in antenatal care and 48 mental health providers at the health centers. Those are the sample size that we use to collect information related to barriers, challenges, and what needs to be done. Next slide. On our next slide, as you can tell, we touch all the districts across Rwanda. 87% of our women were married, 95% attended school, 93%, I can't see very well, but around 87% have access to phone, which is huge. So you can tell and we asked them, is it your own phone or is it a phone that you share? They said, it's our phone. So this is another opportunity for us to use that to create solutions to help them around the challenges that they're going to get. And when we asked them about some of the outcomes, here we're just bringing in, 74% of all women, both those who didn't attend NC and those who attend NC, they say, you know what, we are satisfied, everything is fine. No worries about that. But the more you dig into, because satisfaction is something that is very, very subjective, when you dig into, you found that actually 66% received standard ANC. So we look into the questionnaire and ask them, of all who came here, how many of you received the full standard ANC? We're about 66%, which is a little bit higher than what we have in DHS. Then we have the algorithm of antenatal care, what women are supposed to receive at every single visit. At our surprise, we found that only 9.7% received what they're supposed to receive, which you consider as quality of antenatal care. So, for example, if I came on my first ANC, someone should take my weight, and they should give me the pill, the iron and folic acids. And if I go to my second visit, someone should ask me about my experience, blood pressure, and so forth. So we look at every single visit and check the points. Depending on where women were in their pregnancy, we ask about that. So only 9.7% actually receive what they're supposed to receive. Okay? Then we go to the next slide, where we look at postnatal care. This is the thing. Almost all our women deliver at health facility, correct? And postnatal care is something that is not really improving, and neonatal is something, again, it's improving but at a low pace, right? So we found that of 97% of women who said they delivered or delivered at health facility, we lost around 20-something% whose children were not checked within the 24 hours. Meaning this is another missed opportunity there because I have already mother and the baby here. It doesn't cost me to go and do all my personal checkup. And then when we go overall checkup of PNC, regardless of the timing, we are having around 77%. This is another point that we think we should discuss here because already getting the women, that's the thing, Rwanda is already good at getting all women to come. Once they are there, we should not miss that opportunity. So that's the message of today, that maybe with Dr. Aline and the head of institution, to see what is that need to be done within the PNC, within the delivery room to support these women. Next slide. On our next slide, we also went ahead and understand what could be the drivers on the demand side and the supply side. On the demand side, you know, the majority of women say, you know what, these guys really are doing their best provider. They're very happy with providers. And some of them, they say, actually, we like the way they check on us, you know, child and mother's health status, support of community focus was seen as the key. Community focus, you know, all of them, including the husband. They said the only time that we went there is actually when community focus came to us and said, you should do this. They trust, they believe, actually 200%. Being accompanied by the husband was also something that was valued by the mothers, as well as mother's motivation, husband behavior. That was also something that was good. Useful information provided during the visit, the value information, the package that is being given during the visit, support, and the community focus, that was something that was improved. Supply side, when we say supply side, we are looking at the community focus, we are looking at the providers. We ask them, what do you think is actually a key motivator for you to continue doing what they do? They say, you know what, we like the way we test everything once the mother is like a one-stop center. Additional support, availability of collaboration of healthcare providers, awareness of mobilization of community focus. So everyone here, both supply and demand side, they recognize the effort of the community focus. So our next slide is actually looking at the next slide, factors that are hindering ANC. Our next slide, please. On our next slide, of course, you know, when we went there, this during the Mutuelle de Santé, you know, when they changed, that was actually affecting them as well. The poverty-related issues, the fine was really mentioned a lot by many women. They say, you know, if I don't come, they fine me. And if I don't have Mutuelle, they fine me. So instead of having double fine, I prefer not to go at all, you know, and leave it there. So some of the women say that. Pregnancy-related issues, conflict has become a problem here. You know, we thought that actually, we thought that was not significant, but it's becoming a very big issue. We have another study that we are doing with UNFPA. Small girls, young girls, adolescents who get pregnant, actually, it's because there's no harmony within the family. So I think this has become something beyond our health sector area. Age, shame, specific issues. If you are too young, too old, they don't have a space where they feel like they should organize sessions where two young girls have their own NC so that they don't feel ashamed, or too old as well. Like if we have 50 or something, but I used to tell them, there's no shame, right? You have an example. So, and then poverty, conflict was also something. Insurance has, you know, become another issue. So delays, now this is something that, again, Dr. Aline, I'm putting to you. They say when they come, they wait a long, long time. And sometimes they talk over the phone, health providers and so forth. So women say that. I was like, oh, at least they say it. And also experience appointment at the health facility, availability of healthcare provider, the health center. They will go there early morning, but they'll start checking on them very late in the day, around 11, 12. And community focus challenge in enrollment of process for women. So this is something that also they raised. I think our next slide is on a conclusion. Despite improvement, I think we have some good data that show that digital could be another area of focusing, especially on the demand side. If you look at most of our interventions are happening at supply side, right? You know, how to improve knowledge, how to improve quality inside the health center. But we also have women there, and that's why we would like to bring in the idea that we are discussing here related to digital, using the 70 or 80% of women with access to phone. What is that we can do? Maybe we can start thinking about digital solutions. You know, if you have question, you have AI to support you. If you have, you know, you can even do some consultation online or with AI that can help you solve or understand better why you need to go to NC. That will bring us to our next slide on phase 2 that we are still thinking, and we need to bring it here, is actually to use, maybe next slide, please, is to use a digital tool, and that was the experience of South Africa. I think they're also applying in Uganda, called Mom Connect. Mom Connect is a tool where you get all women around who are pregnant, facilitated by community focus, and also they'll have all the questions related to the pregnancy being asked, and then reminders of when they need to go to the health facility, what are the expectations for every single visit. So they know if I go to my second visit, I'm supposed to have 1, 2, 3, 4. So getting them owners and of their own health, also understanding what they're expecting at the second level. I think that's where we are in terms of discussion on phase 2, on where we need to go, given the importance of information that we get out there, and also supporting women to move on with ANC, especially if we are moving from the 4 NC to 8 visit. We need to think how we can boost actually the demand side. I'll pause here. If we have any question, I'm happy to respond. Thank you so much, everyone, for your attention.
It's going to be a challenge, but we will overcome. Thank you so much, Prof. Chondo, for that insightful insight. I think it gives us some additional insights as to why we are not really achieving the ANC and PNC targets. There's a lot of quantity, but the quality has to be addressed now. I think you highlighted that less than 10% receive the full package. Would want to know how that was assessed during the, how was it assessed? Was it self-report, or was it objective assessment? But you can answer during the Q&A. I think you also highlighted that many women are satisfied with the services, but they may not know what services they're expected to get. So that's subjective. Importantly also is a high digital penetration rate that can be a key enabling factor. So I'll open it up for questions, first to the team online. If there are any questions, please come off mute, introduce yourself, or write in the text, and someone will read it out and get to answer it. Any questions online? No questions yet, but as you're thinking about it, we can have someone in the room if there are questions, discussions, and suggestions are welcome.
Thank you very much. Actually, I'm really thankful for Professor Janine for what the great presentation. I have a small question. You said that the PHQ for mental health, is it computerized? Okay. Now, second question number 2, there is a gap. You said that 20% of PNC women are not checked within 24 hours. So what do you think it's a problem? What is the gap? What is creating that gap?
Let's take one more so that you are able to respond at once.
Any other question?
Yeah, thank you, Professor Janine, for interesting presentation. Maybe mine will be also to complement on maybe some key findings that you presented, because we did also a study in HIV program just to see the missed opportunities. And we've seen this like almost similar findings, especially when to come to the trust of the healthcare, but also the conflict in families. And we've seen that also in HIV program, those who are still transmitting HIV are like those young mothers, especially who are not married. And I think this is almost the same from what you have seen. And maybe some of them, maybe they got pregnancy, unwanted pregnancies. So maybe conflicts and unwanted pregnancies may be also something that maybe the program should be think about maybe how to address it in terms of pregnancies. So my last one will be like it was unfortunate to see that almost 23% or 24% of like children were not checked during postnatal care.
Postpartum depression was very high. I think around more than 70%. I have to check the numbers. So this is something that also brought us to what is like who are silently struggling with issues that we say their poverty, husband, and conflict on top of the depression. So again, we thought that this could be a tool, whatever that we are thinking, again, rely on Dr. Aline guidance, what is that can be done to start at least assessing it and at least open up for women to discuss about the issues related to depression. So PHQ-7 is a very assessment tool on depression that looks at a number of items that it's, how do you find yourself in the range of 1 to 4, like waking up and have a goal to do your work, or feeling that you feel not work anxiety, you can't do your work as usual. So there are kind of questionnaire that you use. It can be computerized, but what we did, we downloaded the tool and actually request women to tell where they are in the scale of 1 to 4, I guess. So we also found that depression was something that in all studies that we are doing now, we are adding the PHQ-9 just to check. Depression is something that is not, it's untold, it's not discussed, and we have mental health there. So we also ask questions related to mental health, how do you call them, mental health providers. Some of them, you know, to find whether or not they found depression is an issue, they recognize it's an issue, but it's a kind of normal thing that you have to live with. So I think we need also to discuss about how they feel about that and how they can support women and the antenatal care services and postnatal care services. So I think, I don't know if I respond to your question. Dr. Rick, question related to anxiety and also issues in the family. I think this has become a very big issue. It goes beyond us. It goes to our next future generation. It goes to kids who are also taking drugs. It goes to unwanted pregnancy. It goes to HIV. It goes everywhere. I think there's a call now. I don't know if the Minister of Health will take the lead on that, but at least there's a call to start discussing about issues in the household that is impacting all the health indicators that we see today. Dr. Rick, I don't know if you respond to the question, but Dr. Lin is going to be well positioned. Thank you.
Thank you so much. For those that are online, please take one question, then have the next presentation.
Thanks, Professor Chondo, for very interesting findings. I have two quick ones. First is the HQ9 tool that you used. Was it validated by previous researchers in the context of Rwanda? The reason I'm asking is that, did you think about maybe Hopkins symptom checklist, because it's the one which is commonly used? And maybe for future study, you might think about maybe comparing the two and see the scores that might be the comparison reason of the score. The second is to suggest that maybe this platform is a way of expanding collaboration. Studies have shown that depression and the maternal stress are being transgenerationally transmitted to the next generations. And there are many markers which have already been discovered, including some of our research projects, where they touch both at epigenetic level and at genome level. So I would recommend, if possible, we expand, maybe we look for a grant to build a biobank for both mothers and babies, then the babies from those mothers, and then we can go together longitudinally to see what will happen. Thank you.
That time, Dr. Yvonne, mental health used for mental health survey, national mental health survey, exactly tool that we used, so that we have comparison. Of course, we can have any other tool. For the grants, I can't agree more, but at least to understand what do you think should be done, so that we go in line with what's the priority, and then we write grant around those solutions. Also, we work with Reach in South Africa. They're also following out online. They've come up with different solutions in terms of Mom Connect, Parent Connect now, Family Connect. It's a way of using family and digital access to improve some of their health outcomes. Over, thanks.
Let's give a big round of applause to Prof. Chondo and the Seeking team for an amazing study. We'll be expecting a policy brief that can be used to influence our policy and programming. And up next, we have Dr. Aline Mumbiei, who is the division manager for the MCCH division at RBC. And it's a good segue into the next discussion. How can these findings be incorporated into the current guidelines, into the current services that we have for mothers and babies? How can we improve the quality? How can we take advantage of the missed opportunities to further advance MCCH in Rwanda? Over to you, Dr. Aline.
Thank you, Dr. Katera, for giving me this opportunity to present. First of all, before I go to this presentation, let me talk about what the Commission on findings of so we have started to get into action and some collaboration. Now actually collaboration together and have some guidelines train capacity building to all health providers these facilities so they can support pregnant women before, during, and after delivery. So we try to overcome this issue of as the generation which follows taking this in advance, so we correct this issue of depression, which is growing as we are finding general for the population. So without taking management, let's go through this presentation where we talk about malaria and depression as comorbidities, and this is a very big concern. Tackle this issue of stunting and controlling disease. We are looking on the nutrition and impact of nutrition on malaria outcome in children. And, next. As a background, so we are first of all to see where we are located in sub-Saharan Africa, and this is where predominantly we are observing the issue of malaria and of course nutrition. And as in Rwanda, we have this population growing, and as predecessors in 2022 we have reached and substandard condition and which are not really promoting good health if we are looking in terms of different health indicators. And malaria and nutrition are the top health consultation issue among the top consultation in the health facilities. And also these are the very big health concern in our settings. Next. As a background, when we are going to remind all of us the malaria, we do have different type of plasmodium, and predominantly we have falciparum in Rwanda, as in other sub-Saharan African countries. And we are also observing different species, malaria and ovale, but as I mentioned, predominantly this plasmodium, the proportion is at 85%. And this is the big issue because the one who is developing the severe malaria. The major vector, we do have Anopheles gambiae and also Phenestis, and following different intervention of prevention. So we have been observing an increase in behavior changes of these mosquitoes who are biting outside, so to develop their, to lay eggs, and so they need blood, and they go feed on cattle and on other animals so they can develop this. And as most of the intervention used are indoor, so they have changes this behavior going outside and bite and earlier as they can. So you can find some people are using nets properly, but they still get malaria. And in terms of symptoms, they are not really specific for malaria. That's why, since 2009, we have adopted a compulsory diagnostic to use either RDT or blood smear, both at community level and in all health facilities. And the cycle to have malaria, we need to have at least 3 components. So we have a human being, parasite, and also mosquito. And all the 3 together, there is this issue of perennial transmission. So that's why we are looking at maximum how we can eliminate this parasite in circulation, because in any case, mosquito will remain available, but we need to have those mosquitoes we are not having any parasite. And to arrive at this, we need to have accurate and drugs, and also people are consulting earlier as they can, so we cut this issue of transmission and also the parasites, not giving them the chance of developing the gametocytes, which are the sexual stage of these parasites. Next. In terms of intervention, a lot have been done since 19th, and as you are seeing, also the routine system that are being collected through existing tools which are giving us accurate data where it can be used. And within the program, data are being collected on a monthly basis using different channels, HMI, SysCom, and data are available at lower level and also central level, and are being used every month to observe any change. So then we have this graph we are showing us the way the malaria have been changing. So when we are looking from 2000, I don't see well, from 2008, 2009, we have reached 1 million, above 1 million, and in 2011 and 10, so we achieved a very low malaria numbers, malaria cases, where we have trying to change our direction to pre-elimination phase, but due to other factors, and malaria were upsurge, and until we get up to almost 5 million in 2016-17, and these were based on different factors, insufficient preventive measures, and also we observed that we have also in terms of increasing of resistance of pyrethroids in ITN used, and also some reduction in terms of number of districts who are receiving IRS. And this, we were having also in that period a contingent malaria plan where we're working with different ministries to try to overcome this issue of malaria increasing. And at that time, we were even treating only case of malaria at community for under 5. Then the idea of treating all people come in, where we're also doing a prompt and access, diagnose and treatment and track of case at community level, which help us to reduce malaria. Then today, we are at below 1,000 cases, and this were achieved, and also in conjunction with increase in number of the IRS districts, where come from 5, 8 to 12, and one district where they were targeted this intervention. Next. Please moving. So in terms of nutrition, if we go briefly in terms of background, it's also a concern globally, where we do have an issue of stunting, in which numbers can go up to over 100 million of children under 5 being stunted. And in Africa, the Eastern and Central Africa have the highest stunting rates. And this is varying from 36 to 32 respectively. And this is data that are of 2017. We can say they're outdated, but they're showing us the situation now is the concern is. And this is also based on a recent DHS, which was in 2019, 2020, the situation looked the same, because when you look in terms of percentage, it's not far from the Eastern African data available. But these are different nutritional index we were looking using the DHS data, and as you are seeing, we are looking on stunting, underweight, and also wasting, and looking on the different definition by WHO, and also these charts we're using, and also there are different charts based on different age and sex. So to try to balance and see, because the needs in daily intake or expenditure are very different, and also are looking on this age and also sex. Next. For also in terms of nutrition, is that also this a lot have been done in terms of intervention, and some of them we can also say about the 1 cow per family, which is also doing a lot in supporting families to feed kids where they are receiving milk, and also other intervention like fortified foods. And as I was even mentioning, so this is from other source, and we see that the change, we are seeing that the overall change for different years, when you see from 92 to 2002, only we have a decrease of, it's not readable, but when we see it's only 1% per year in average, and also after increasing this different intervention, we see that at that point also remain an issue despite increase in terms of intervention and whatever we are doing in availing foods, education of mother in different existing channel, but we see that the trend in terms of the reduction in this issue of stunting is going very slow, and only 1% per year, and we are asking ourselves what is going behind of this, what are the factors, so try to understand how we can correct what we are doing as routine and try to bring other new intervention which can help us to decrease this issue of stunting. Next. So here I'm going to talk about what we're looking on existing data, how we can explore and use them, and helping us without using a lot of means, do new studies. So here we looked at, we took the DHS data set, then we tried to analyze and see the data in terms of malaria and also nutrition available, and try to do the analysis and the relationship where we were looking, and where we looked at this achievement and also the incidence reduction, drug resistance, terms of change in mosquito behavior, and also we found that still a lot is needed to be done. But again, data show us, you can go. This is what I've been saying when we look at the data set of DHS. Next. We try to look on different periods the DHS was collected, because we know that in terms of malaria there is issue of seasonality, and we looked at the period when the DHS 10 were collected. The period was November to January. The second one, the same, but in 2019-20, we will have an interruption of data collection due to COVID pandemic, and we resume in May, June. So when you try to compare this data, we did it with a big attention, because the third one period, the difference of data collection period could give us some difference in terms of conclusion if we see any difference in what we are getting as information. Next. So we looked at this, and overall rate of malaria cases were very low in terms of, because the target age were looking below, children below 5, and based on different intervention, we are observing a change in epidemiology. So children under 5 and pregnant women are not really a big concern, so it have changed to young adults, so they are most affected, and this is different. We will have looked on the factors behind, so we found that maybe, and also young male, so they tend to stay outside long compared to women and also kids, and not using preventive measures as others are using, so even to attend to seek treatment. So this is something I've been observing. And when we look at this data for the adjusting or not adjusted variable where we're looking, so we found that kids who have malaria have a big chance to be stunted, and the risk were even doubled when they have malaria compared to those who are not having the issue of malaria during the survey. And these were statistically significant. So then what will come from this, we say we have a lot of data sets. So for us to try to orient the program, it's a matter of using them, explore. So it's not only this who is available, but there is other thing. But from this, we are having only the situation to give us the information that it can give us this and this, but we don't know really the real cause. When we looked, we try to understand in terms of what they are taking, like foods, the energy, their expenditure, and also looking on that, why they don't, they are tending to get sick compared to others. Next, that's why came the idea of doing this cross-sectional study. So we're looking on the role of macronutrient and micronutrient in the control of malaria in Rwanda. So try to understand the real cause or the root cause of this, where you can go in some villages, then find some kids are sick and others not, and try to understand in terms of what they are taking as food. So, and this is how we had this idea, and the problem statement was that why we need to know people are most affected in this high risk, where they do have a lot of high risk of macronutrient or micronutrient deficiency, and also to try to orient different intervention in terms of increasing what they are taking, fortified food, so we know really the gap existing in what they are taking in some different area. Because all the time we're asking ourselves, where we get a lot of stunting in the northwestern part of the country, it's a place where we have a lot of food. Then all the time we are asking ourselves, why this? When you compare to those who are staying in the east and south part of the country where they tend to not have a lot of. Next. On the slide. Okay, this is the questionnaire we use. Next. We use also this chart to try to show, then to have really, when the questionnaire were given to parents, to try to show them so they understand if they're giving you the information on the food they're providing to their kids, and show, and also the quantity for having a data in terms of information collected. For example, this plate showing the day of the visit, so they try to weigh the beans they were giving and showing the portion of the beans in the plate, then weighing it and try really to have accurate in terms of collecting the information. Next. And we use a ProNibel. This is a software where we put the food and it generates the information in terms of macronutrients and micronutrients. So we have this table when we are putting all the information, but as this tool it's a Belgian, we don't have our tool. And we're looking also on some table of composition from the West African where we have similarity in terms of food. And what I can mention is that for the Rwanda, it's something which is under development. So we will use our hours, because there is some also, what you can say, the accuracy in terms of number of proportion it's giving you, because it goes also on the way you are preparing your food, time, heat, and also all the ingredients you are putting in. So we try to use this as a proxy, the West African table of composition, and also this tool where we are putting and to generate, it gives you a different information of foods, and also the proportion of all the macronutrients, carbohydrate, protein, that person have been consumed in terms of week, and also during 24 hours, then you can do the analysis and understand what they have been receiving. Next. This is different variable we are looking. So for the analysis, we need to see the basal metabolic rate, where we weight and do everything, the physical activity determination based on the age, because we are not doing same expenditure when we are doing different activity. There is also this information daily of energy intake, which were taken in terms of food. Data validation were done. And also these anthropometric measures, where we are taking for all the people interviewed, and we looked on the macro and micronutrient intake based on the tool I've been just showed you, which have been used. Next. This is a preliminary findings where we collected information for 146 people who have been having malaria, and then among them, we had 4 pregnant women, but as we didn't know the information regarding the weight before being interviewed, so they were removed in the analysis. Then we remain with 85, where we did the analysis, but among these 142, then we found that there was some information under estimation of food intake and also overestimation. These were removed in the final analysis. Next. Remain with 1 minute, then go faster, fast. Then this is what it shows us, that also in terms of age, there is difference, and we see that this is very significant. And when we look in terms of one indicator of underweight, then we see that also this kids where they tend to be stunted, there is also this difference, which is statistically also significant. Next. this map shows us, when we say we are looking per province, data were collected in Bugesera, and south we took the data in the Ruhango and Nyamagabe, and west part of the country were in Nyamasheke and Rusizi. So this, we're looking on overall data, the 85, it shows us that the energy intake for the east were almost 100%, in the south, 92, and 91 to the western part of the country. And in terms of lipids, it's 77 in western, 71 in the east, and 65 in the south. So you see it's very low, even for the old district. And for the glycids, the intake were at 122, 117, 125. So here we tend to see all our population, they're taking a lot of carbohydrates in their plates, few vegetables, rarely fruits, and also you see there is issue of fats, and also what they are taking, like food which have fiber. But again, we see, depending on the variety of food they have been taking, we see that in the south, there is a lot of fiber in what they're taking compared to other places. Next. Here, looking on the macronutrients they are taking, it is very low for almost all the macronutrients when you look on their composition, and very low in vitamin D, zinc at 69, and vitamin A, very low for the western parts. And this is the micronutrient boosting immunity, and when you see in those parts, it's very low compared to the east and south part of the country. Next. Yeah, I'm done. Here we're comparing for the, this is where we are looking on the different macronutrients we have mostly looked and comparing to the low, medium income country. And you see that there are a lot where we are also lagging behind, especially for zinc, vitamin A, and also calcium, pointing those three. And we know all of us the role they are playing in boosting immunity, and which is protect also this issue of contracting all different infectious diseases. So next. So what we are doing now is to have an information and a good data analysis where we can have a good information and being generalized for the country. So we had an idea of doing another round of data collection so we can have a big sample size and have an information which will give us an information which is very tangible and help us to do what we are doing as changing, orient the program in what we are doing. Thank you very much for your attention. And if any question, insights, it's welcome.
Thank you so much. In the interest of time, thank you so much. There is a question online before you go to sit. Where is it? Chuzuzo says, I would like to know if you have considered the nutrition aspects on the immune system, immunonutrition, and how they might be linked with the incidence and prevalence of malaria in mothers and children.
Thank you, Chuzuzo. So this is something which is being part of this survey. So the also immuno aspect will be checked. And for now, I was only talking about the nutrition aspect, but for this big survey we are doing, also the immuno aspect is being looked, and which will be complementing what we are seeing, because what we are taking as food, and this is what is coming out. Of course, the food we are taking, this is translating in what we are having, like boosting our immunity and whatever we have for preventing diseases.
Thank you so much. We don't have time for other questions. Let's go to the next presentation, and then if there's time, we can ask the questions at the end. as we are moving to the next presentation. Thank you so much, Dr. Aline. Please give her a big round of applause. For those that have been in the room, you've now been sitting for 2 hours. So please stand up, grab a cup of coffee, something healthy at the back, a fruit preferably. As we move transition, just grab and come and sit down again. Yeah, as we transition to the next presentation, and maybe as you're walking, you can catch Dr. Aline to get your question answered. For the online team, please give us 2 minutes. Thank you. Just pick and come. Don't talk.
Tujye gufata no ahubwo reka ndebe Clarisse arakaho. Excuse me, doctor. Hari slide ndabona ishobora kuba ya dropinze ikava mu mwanya wayo. Would you mind? Yes. Ndebera kuri yari twatugiyeho. Okay, komeza. Hari slide yagombye kuhitiza hano. Oh, ndabona hangaye hari. Ahubwo bya dropinze hangaha. Thank you. Sorry. Meze bite se? Bari kumamagara ndi hano. Turaza kuvugana. Hey. Sisi highlight zizaba zikenewe hari ibindi ni highlight. Iyi myanya nayo. I know me ukuntu mu gikoresheje. Oh, sorry. Ngiye turahuye. Sava? Makuru. Narakubonye Masaka rimwe ngiye kugusuza mbona wisu uncika imbere y'ibitaro. Nanjye nje ninjiramo gutyo. Nakubonye abikoza tukazi mu gatondo. Nje ngera kure ninjiramo irobona ndenga hariya ku bitaro nkagera hariya ku ikoni ku gahanda gakatamo k'igitaka.